All right, good afternoon and welcome everyone. We're really thrilled to have you on the line with us today for this afternoon's webinar. This is the second webinar in our three-part T-TAC webinar series, the foundational elements of early childhood mental health consultation. There will be a third part coming up next week on June 4th that we really hope you can join us for as well. My name is Meg Beyer. I am the Assistant Director of Strategic Operations at the McSilver Institute for Poverty Policy and Research, and I am one of the partners for the T-TAC project. And again, I'm just really happy to be on the line with you and all of our presenters today. So I'm going to run through a few logistics about the webinar before our presenters begin. As we've done in the past, this webinar is being recorded and it will be posted along with the slides to the T-TAC website. So if you want to share this information with your colleagues or revisit any information, you will be absolutely able to do so. We are going to be taking questions throughout the webinar, and we ask that you chat in your questions using the chat box functionality, selecting the All Panelists option on the drop-down. You'll see if you look at your WebEx screen on the right-hand side, there's a little arrow that points down. If you click the arrow and you select the All Panelists option, that way all of our presenters today can see the questions that come in. And my wonderful colleague, Kevin, who is acting as our WebEx host today, is collecting all of those questions into a document. So we have set aside time at the end to address these questions. And I know sometimes we get a lot of questions because this information and material and content is so important and relevant. And I just want to say that if we don't have time to address all your questions, please know that we are still collecting them, and we'll do our best to follow up following the webinar if we can't address all of the questions during the webinar. For those of you who are LMSWs and LMHCs who are interested in obtaining CEUs, you must attend all 3 webinars in this series. Further information is going to be distributed via email following the webinar series completion. This will direct you as to where you need to go to complete your process in terms of CEU completion. But just know that in order for you to receive CEUs, you have to have attended the first webinar, which was last week, today's, and you must attend next week's webinar as well. And then finally, towards the end of the webinar, we are going to be sending out the feedback survey using the chat box functionality. So you'll see our McSilver admin host, Kevin, is going to chat out a link that will lead you, if you click on it, to the feedback survey. And we're asking you to click that link and fill out the survey and provide us with your feedback, because we do read all of these. We appreciate your feedback, and we really try to, this feedback really allows us to enhance our future T-TAC offerings and understand your experience in these current offerings. So with that, I want to thank you all for joining us, and I'm going to hand this over to my dear colleague, Evelyn Blank, who will walk us through some more logistics before we get started. So Evelyn, go right for it.
I am the director of the New York City Training and Technical Assistance Center, which is funded through Thrive New York City in partnership with the New York City Department of Health and Mental Hygiene. T-TAC is a partnership between the New York Center for Child Development and the McSilver Institute on Poverty Policy and Research. New York Center for Child Development has been a major provider of early childhood mental health services in New York, when we have expertise in informing policy and supporting the field of early childhood mental health through training and direct practice. And we're very fortunate to have a subcontractor, NYU McSilver Institute for Poverty Policy and Research, who house the community and the managed care technical assistance centers, otherwise known as T-TAC, MCTAC, which offer clinic, business, and system transformation support statewide to all behavioral health providers. T-TAC is tasked with building the capacity and competencies of mental health and early childhood professionals, and we do this through training and ongoing technical assistance. And I just want to direct you to the next slide, which is a screenshot of our website, and encourage people to really go to the website to learn about upcoming events, to access resources, but also to access archived webinars and past presentations. So we are thrilled to have everybody join us for part 2 of a 3-part series, beginning at the beginning, the foundational elements of early childhood mental health consultation. So it is now my privilege to introduce our presenter, Kadija Johnston, who has been a real true pioneer and a thought leader around infant and early childhood mental health consultation. Kadija Johnston is a clinical social worker who has been a practitioner in the field of infant and early childhood mental health since 1985. For the past 15 years, she has been the director of the Infant Parent Program at the University of California, San Francisco. She developed an approach to early childhood mental health consultation that serves as a model for other organizations, locally, nationally, and internationally, and as I said, has been a true pioneer and a leader in this field. She's provided technical assistance and training in 23 states as well as internationally. She also serves as an expert advisor for and continues to be involved with the SAMHSA-supported Center of Excellence in Early Childhood Mental Health Consultation. She's a founding member of RAIN, a group of national experts advancing practice, policy, and research in early childhood mental health consultation. Ms. Johnston writes and lectures nationally, and in addition to the numerous articles, she co-authored a seminal text on the subject, Mental Health Consultation in Childcare, Transforming Relationships with Directors, Staff, and Families. So it's been my privilege to work with Kadija Johnston, and I look forward to a very stimulating presentation. Thank you, Kadija.
Thank you, Evelyn. I'm pleased to be back together, even at a technological remove. I have to say that the webinar format was not how we initially envisioned offering this material, but after the first one, I'm really rather liking the progressive process of a 3-part series with these periods of time in between. I hope that for all of you who are participating, it affords a pacing that promotes reflection and an opportunity to metabolize the material before asking you to digest more. So welcome back to those of you who were with us last week, and welcome to those of you who are joining for the first time. Today, in this, our second session, we're going to return to and build on the foundational principles and practices that I offered in the first webinar just a little over a week ago. I think especially in these untethered and turbulent times, reminding ourselves of fundamental values and theoretical premises is, I hope, a way of steadying ourselves in the work and in the world in general. Grounded in and expanding on last week's introductory session, today our topic is the consultative stance. This is a term that my co-author, Charles Brinamen, and I, in our text on early childhood mental health consultation, coined. And the phrase refers to characteristics of the consultant's comportment in practice, and particularly our way of positioning ourselves in relationship to our consultees. In the late 1990s, my esteemed and cherished colleagues, Jeree Paul and Maria St. John, offered us the maxim, and I quote, "How you are is as important as what you do," inferring that our ability to empathize with and establish relational processes is integral to the efficacy of all early childhood mental health interventions. In application to the practice of consultation, this premise asserts that the power, or conversely the futility, of the consultative relationship really lies in the consultant's way of being, what I call the consultative stance. In this time of major transition, much in the world and therefore in our work as mental health consultants is, and I imagine will continue to change, how we offer consultation services, where those services take place, and how proximal we can be to the caregivers to whom we are providing consultation and the babies on whose behalf we are doing so. All of that, I know, is in flux for all of us. while what we need to do may look very different than just a few months ago, what stays the same is who we are and how we approach the work. So I really appreciate today being able to present the principles of the consultative stance, who we are and how we are, hoping that these can be anchoring ideas for all of you at a time of great sea change. And I want to say, I don't mean to imply that our professional demeanor shouldn't and can't be cultivated and refined over time, and of course will change to some degree in response to the current circumstances. In fact, from my perspective, we have a clinical responsibility to reflect on and regularly revisit our clinical comportment. And today I'm going to give some examples even of adaptations and ways of employing elements of the consultative stance that are responsive to the new and evolving conditions related to COVID-19. Nonetheless, at its core, the consultative stance, like each of us, remains the same. The consultative stance is premised on and adapted from those conceptual pillars that I spoke extensively about last week in our first webinar. But in keeping with what I just said about the benefit of revisiting concepts and revisiting and reflecting on them, and for those of you who weren't with us last week, I'm going to offer a really distilled version of those principles. So to put it in context, the consultative stance is a component of a relationship-focused, dynamically and equity-informed approach to consultation. This approach, and therefore the consultative stance, is founded on several conceptual pillars. The stance is derived from concepts connected to professional consultation, equity, and psychodynamic and infant mental health principles. So let's look briefly at these bodies of knowledge and what they contribute to mental health consultation and to the stance. First, in terms of mental health and infant mental health principles, beginning with a psychodynamically oriented orientation, psychodynamically oriented consultation pays attention to really inner psychic constructs like the unconscious and defenses, the things that as human beings we use to make sense of the world and protect ourselves. In mental health consultation, I'm suggesting we examine and address the influence of these processes, first to better understand and help ameliorate difficulties of the children who are the focus of child-specific consultation. But I am also, and perhaps even more importantly, suggesting that we apply these concepts to adults, that we approach our consultees with what I refer to as a double consciousness, that the child care provider and perhaps the parent of a child who is the focus of consultation, that these adults are viewed as both colleagues and clients, not in the sense that they're patients in therapy, but what I'm suggesting is as someone to whom the consultant applies her clinically informed understanding of human motivation and human behavior. Addressing internal processes that distort a provider's perception or interfere with her ability to integrate new ideas or change her behavior toward a child is integral to the efficacy of our consultative efforts. Of course, the consultant's knowledge is important, but the consultant's advice or knowledge can only be usefully contributed to easing a challenging classroom conundrum or understanding a child's perplexing developmental profile in as much as the consultee has interest in and what I would refer to as psychic space for entertaining new information. What I'm suggesting is that our projections based on bias from past experience or a defensive structure of a provider can obscure one's ability and the desire to entertain alternate ideas. If, for example, a provider's unconscious racial biases cause really malevolent misattributions about a 2-year-old African-American boy's inadvertent swipe at her face during a moment of distress, it is really unlikely that offering developmental guidance about what might help regulate or re-regulate a toddler during times of distress will even register or penetrate that misperception. Of course, differently implied than in treatment, and only in relation to work problems for which the consultant's assistance has been enlisted, addressing inner psychic processes is critical to the capacity building aim of mental health consultation. What infant mental health offers, I think, is a view of development as a transactional phenomena, which informs our consultative practice and shaped my notions of the consultative stance. Specifically, ideas about how development and growth occur or conversely are derailed for both children but also for adults. From an infant mental health perspective, when asked to consult around a child who is distressed or delayed, what I'm suggesting is we don't look for what is deficient in the child. We look at relational contributors, relational disruptions, or relational trauma. We look for relational contributors to help us make meaning of the child's behavior. Conversely, we rely on relational remedies. In consultation, we assist the adults in a child's life, child care providers and parents, to offer reparative relational experiences. In the stance, these notions are adapted to what I saw as necessary for individual and institutional change to take place. So the other set of principles that I talked briefly about last time, and we'll revisit, are related to equity. Acknowledging the structural inequities in access to and the quality of both mental health and early learning services for poor, primarily children of color, early childhood mental health consultants have an opportunity, and I believe a responsibility, to really contribute to addressing these long-standing patterns of injustice. This commitment begins with and regularly returns us to examining ourselves. I want to say that for me, the explicit examination of my whiteness and the attending power and privilege that affords me, as well as my biases and my being complicit in oppression, my looking at that explicitly began in earnest fairly recently. While the consultative stance, as I wrote it more than 15 years ago, inherently promotes the examination of power and privilege and bias, I have been increasingly and more overtly incorporating an equity perspective in my discussion of the stance. Really promoted by and along with what I will refer to as my equity and diversity forward colleagues from, as are listed here on the slide, the Diversity Informed Tenants Work Group and my colleagues from the Indigo Cultural Center. I've really been working to identify and speak to the intersection between the elements of the consultative stance and principles of equity and frameworks of equity. And one of those frameworks, which I mentioned last week, is the Diversity Informed Tenants, which grew out of the work of the Harris Foundation Professional Development Network. And the tenants, which I have given you, as I promised I would, the link to here. The tenants are a working aspirational document that puts forth a vision of a society and of the infant mental health field in which all children, regardless of race, ability, or family structure, can be recognized, respected, and well served. Among other valuable services, I also want to mention that the Diversity Informed Tenants Work Group and the Indigo Cultural Center staff, both referred to on this slide, offer racial equity training and consultation from a place of deep knowledge of the field of infant and early childhood mental health, and are worth looking at to integrate into our thinking. have radically changed and enhanced my inclusion of equity principles in the consultative stance. So these principles that I just presented, these principles, these sets of seminal knowledge inform the consultative stance and serve to guide our conduct as mental health consultants. What we pay attention to, how we impart our expertise, or conversely hold back from telling people what to do, the care we give to mindful self-regulation and reflection because we are convinced that our treatment of others matters to how they in turn attend to the children in their charge. The cultivation of a particular demeanor. This is what I'm going to convey and I hope is conveyed in the consultative stance. As mental health professionals, our demeanor is crucial, of course, in all aspects of our work. But I'm content it's especially influential in consultation. Why? Why more so in consultation than in other modalities of early childhood mental health service? Because as an indirect intervention, our efficacy relies completely on the consultee's belief that who we are and what we have to offer is credible. They won't enact any of our ideas if they don't trust us. Also, the provider and parent, not us, the consultants, are agents of change. Regardless of how accurate or even brilliant we may think our ideas are about a distressed or distressing child or how to address a thorny classroom conundrum, those ideas will be taken in and implemented only if we have truly been taken in by the consultee, if we've created a genuine partnership. And the elements of the consultative stance guide us to that kind of authentic collaboration. I want to turn now to research that is confirming what the consultant's demeanor means, and that the consultant's demeanor and relationships that she creates as a result of her demeanor is a powerful instrument of change. Focusing on the characteristics of mental health consultation that correlate with effectiveness, in 2006, Green and her colleagues found that the quality of the mental health consultant and consultee relationship was the single most salient predictor of efficacy of consultative services. And then the subsequent studies listed here confirm that link between the strength of the consultant-provider relationship and added a range of positive program, caregiver, and child outcomes that seem to come out of a positive relationship. These outcomes include greater teacher sensitivity, warmth, responsiveness. A positive consultant-consultee relationship is especially impactful when the child who is the focus of consultation is a child of color. Of course, I have to say it's been gratifying that research reifies my experience, but beyond being satisfying to me, these studies are identifying specific components of the consultant's comportment that lead to meaningful change. Particular traits are emerging as emblematic of effective consultation relationships. So I just want to highlight a few on this slide and the next one. To the extent to which the teacher and the mental health consultant perceive that they are partners in the work matters mightily. The consultant's warmth, a sense of, as consultees called it, authentic interest in their experience, and positive emotional tone of the interaction really heightens its impact. The strength of the consultant-consultee relationship is facilitated by a consistency of availability, meaning that the more time consultants spend with and in the center matters. It also has been found that the strength of the relationship matters in terms of perspective taking. the consultants being a clear communicator and showing respect for the unique culture of each child care center also contributes to a positive relational sense. And the willingness to explore, lean into difficult topics was cited by child care providers as contributing to a positive relationship with the consultant. The other aspects that are really noted by child care providers as essential to the relationship are what I refer to as notions of non-hierarchy. Identifying the consultative relationship as the primary predictor of beneficial outcomes, positive connections were consistently described by child care providers in egalitarian terms. In the affirmative, being perceived as a partner or team member was an essential quality to a positive relationship. Oppositely or conversely, if the consultant adopted what was perceived as an elevated or expert position in relation to the providers and parents, it was seen as a derogatory attribute and impeded the relationship between providers and consultants. So I'm going to ask us to keep these findings in mind when we turn to talking about the consultative stance. I think what you'll notice is some of the exact terms that providers used, as well as several of the general traits, are actually articulated and emphasized in the stance. These findings from research speak to the efficacy of early childhood mental health consultation that appreciate the transactional nature of development, not just for young children, but I would suggest throughout the lifetime. What I'm speaking about is that these results say to us something about how change happens in adults. When engaged in a relationship characterized by mutuality, compassion, and genuine interest in the provider's subjective experience, the consultee is then free to start to explore the conscious and unconscious impediments to understanding the children who they care for. The kind of intersubjective space in which that exploration occurs also affords moments of genuine attunement, and these experiences create new avenues of understanding, and consequently, I would suggest, shift the provider-child relationship, which is the overall aim of mental health consultation. I want to, for a moment, look at, though, the very special role that the consultant-consultee relationship seems to have in affecting racial bias. In a very recent study, Annie Davis attempted to answer the question, how and for whom does mental health consultation work? She was specifically interested in looking at whether it is working for young boys of color. Her study assessed whether variables related to race and culture affected the consultative relationship and whether it affected outcomes of consultation and the link between the two. And what Annie Davis found was that the quality of the consultant-consultee relationship, it had a significant impact on outcomes when the child who was the focus was a child of color. The more positively the teacher perceived her relationship with the consultant was directly related to being more positively attached to the child who was the focus of consultation, and the greater the provider, the child care provider's confidence in her ability to care adequately for that child. What also mattered was the consultant's capacity. Consultants who engaged in study and self-examination related to equity and rated themselves as having high sense of skill or competency in culturally responsive practices, those consultants were viewed by teachers as better partners, and in turn, the child on whose behalf they collaborated benefited. It's important to also acknowledge that racial and ethnic matching between the teacher and the mental health consultant bolstered these beneficial outcomes. these results suggest, I believe, that an explicit equity focus and racial sameness exponentially enhances the effectiveness of early childhood mental health consultation in addressing racial injustices. So what do we learn from taking all of the outcomes of this research kind of together? Taken together, all of this research and my anecdotal experience point to the fact that without a perceived positive relationship, all of our good ideas and expert advice are only minimally impactful. Even when content expertise of consultants in those studies I just mentioned, even when content expertise was cited as salient, the manner in which the consultant conveyed that information was more significant. More importantly, I think, is that information is not the only thing lacking or needed to understand and respond to children effectively. Mental health consultation contributes context expertise while concomitantly addressing internal processes related to those foundational principles I mentioned. So I hope that it's reassuring to be reminded that what matters most is the way you engage. But I don't, by speaking so extensively about our internal capacities for relatedness, I want to stop here and say I don't mean to imply that knowing, that having an expertise is not important. Expertise for mental health consultants in an extensive range of topics is essential. We need to be well-versed in development in all of its vicissitudes, from the perfectly common to the extremely unusual. And we need to know a lot, not only about development, but about how adults learn and grow and change, because most of our work is with adults in children's lives. Beyond child and adult development, we have to be familiar with how systems develop and organizational structure, as well as with philosophies of pedagogy in these organizations that we consult with. Competency in understanding and addressing trauma, historical and contemporary trauma, as well as addressing the impacts of other forms of oppression are called for. Knowledge of neurobiology and sensory experience and individual differences, and I could go on, are essential. And these competencies have been articulated by a group of us at the Center of Excellence for Infant and Early Childhood Mental Health Consultation, and I hope, having given the link, that you will look at those. But what I am suggesting is that we devote equal energy to cultivating relational competencies and the qualities of comportment that are evidencing themselves as the mutative factors in early childhood mental health consultation's efficacy. So here I have been speaking to and list the elements of the consultative stance. There are 10 of them listed here, and I'm going to touch on all of them, maybe linger a bit longer on a few that to me seem particularly seminal, either generally or to be particularly meaningful in the current circumstances in which we're all trying to function, but all 10 deserve to be explored in far more depth. So I hope this is just an introduction for those of you who are interested in learning more. So let's begin with the first, parallel process. Parallel process is first because it's the cornerstone, in my mind, of the stance. The findings of the research I just described, I think, are in large measure reporting on the power of parallel process. It's, of course, an axiom of mental health. The concept of parallel process asserts that the ways in which people are treated affects how they feel about themselves and treat other people. And as I mentioned last time, my mentor, Jeree Paul, coined the platinum rule around parallel process, saying, do unto others as we would have them do unto others. And as the consultant, this suggests, as the mental health consultant understands, attunes to, empathizes with the provider and parent, they will be better able to understand, attune to, and empathize with the children for whom they care. Our experience, meaning my program's experience, actually convinced us, and our formal process evaluation confirmed this parallel relationship, and it's important. As I refer to in this slide, when we first began our program 30 years ago at the infant parent program, the child care programs who had requested our consultation, we looked at through a process evaluation. At the time, the only mechanisms for looking at some of the ways in which mental health consultation impacted those programs was the ECHRS, the Early Childhood Environmental Rating Scale, not a perfect measure of mental health consultation. But what we found was that those programs reporting on the ECHRS, the greatest degree of organizational difficulty, rated lowest on quality indicators. What I mean by that is that those programs who engaged mental health consultation to think with them about inner staff difficulties or parent-staff conflict. So these were programs that struggled with managing transitions with children, where pleasurable interactions with children were rare, where reprimands replaced guidance. What I'm suggesting is that we can then infer that these difficulties can be overcome, and these type of problematic practices with children can be revised only by addressing systemic difficulties involving and affecting the adults in those children's care. Only as providers feel respected, clear about what is expected of them, and able to anticipate changes will they treat the children and families they care for similarly. So what this stance is suggesting in terms of parallel process is that the consultant offers a relationship characterized by these qualities, while simultaneously engaging the child care community, especially the director, in coming to appreciate and attending to the impact of adult relationships as contributing to the overall quality of care. I think that parallel process can be especially powerful now. What I mean is that plans are beginning, at least in California, I'm sure it is coast to coast, plans for revamping and reopening child care centers are starting to take shape. And as they do, at least in my experience, the anxiety and fear, as well as outrage at amplified inequities, are understandably intensifying among child care providers and parents. I'm wanting to remind us that early childhood mental health consultants are well positioned to act as antidotes to the resulting dysregulation of the current moment. We can prepare the providers and parents to offer more equanimity to the children they care for. A calming and containing countenance, composure in the face of uncertainty, and tolerating strong shows of emotion can be beneficially transmitted from consultant to consultee to child, the parallel process. However, I just want us to remember that parallel process works in all directions, and that we mental health professionals are right now not immune to the impact of the global pandemic. So we want to regularly assess our capacities and be lenient with ourselves when we are not immediately or always able to act as co-regulators with our consultees. and that we work to regularly return to that state. So the next element of the consultative stance is to consider the provider-child relationship in the context in which it occurs. And that relationship between a provider and children can't be meaningfully considered, I don't think, or addressed separate from really an understanding of the many systems in which it exists and unfolds. And so to this end, the concentric relational rings surrounding the provider-child relationship are attended to. And again, in child care, this means attending to adult relationships. What I am suggesting is that the consultant begins, and by begins I mean when you're starting a new consultative relationship, by communicating our wish to get to know and develop an understanding of the people and practices in a center. Through direct questioning and observation, we seek to learn about guiding philosophies and daily routines, and the consultant wants to inform herself about the relational styles of each of the providers with whom she's working. And we have to develop an understanding of each provider's role expectations, their emotional capacities, their beliefs about development, as these are inevitably expressed in their attitudes toward children. A provider, a parent, or for that matter, a consultant's attitudes and beliefs are, of course, multiply determined. When we engage parents in treatment around their child, we assume and therefore inquire about the ways in which their experiences, their cultural values, and their history impact their parenting. And I think although we know better, we often act as if with providers that their professional training will take precedent over their beliefs and their personal experience. I'm suggesting the opposite, that attributions ascribed to a child or to one's coworker, and that the feelings that arise can trump or at least temporarily obscure the knowledge that a provider possesses. So I'm suggesting that we apply the same relational rationale to learning about the myriad influences on child care providers, that we want to learn about their worldview, their ways of doing their job, as this will be what matters to how they care for children. And that in addition to gaining an understanding of relational and program elements, I think it's an essential part of getting to know a setting by understanding what their expectations of consultation are, so that we want to ask ourselves and assess with a setting who asks for consultation. We want to ask them and know who invited us, what exactly is being requested. One of the questions I'm often asking myself and finding ways to inquire about with providers is, can the wish to slow down and consider the meaning behind behavior be tolerated? I also want to know, who do they expect and hope me to be as a consultant? And I ask myself, what do I expect of myself? We also want to know, is there a previous experience of mental health consultation or other quality enhancement providers? Why? Because previous expectations are based on previous experience and will be expressed in what is asked of us. Of course, the context right now is changing in childcare. And with these shifts, so will relational expectations. I think there will be heightened and different needs that may be expressed as demands or frustration or disappointment at what early childhood mental health consultants can do. Even though slowing down is exponentially difficult in times of crisis like this, what I'm suggesting here is an encouraging of us to step back, to survey, to get to know the new and changing landscape, to ask ourselves these same sets of questions even in situations that maybe we've been consulting in for a long time. Once we've gotten a sense of the current or existing context and the relationships in context, then we can move on to the next aspect of the consultative stance, which is to attune to subjective experience, appreciating the power of the provider's subjective experience. The consultant listens for and with permission explores aspects of a provider's perspective that influence or interfere with her ability to sensitively respond to the messages a child's behavior sends. Here's some examples. A teacher's history of abuse leads her to label an infant's clenched fist and sober stare as a possible predictor of that child's violent tendencies. Or having had to leave her own children behind in her home country, a child care provider expresses intolerance of an infant's displays of dependency needs. Immersed in a society that tells us that African American men are threats, an Asian American teacher sees an energetic 3-year-old African American boy's displays of dexterity as aggressive. What I am suggesting is that these lenses that come from internal processes and past experience, these lenses that lead to these interpretations also predispose the providers to misinterpret these children's needs and, of course, to then respond to the behavior in a way that is inappropriate and unhelpful. Removing internal impediments to adequately interpreting children's behavior is a prerequisite to developing more attuned, responsive action in response to that child. Of course, in addition to what I'm describing as intrapsychic pains or pleasures, there are multiple other influences on how child care providers view children and do their job. And what I'm suggesting is we need to consider the multiple influences. Although some are internal, caregivers, like any of us, are affected by external pressures and other people. Licensing requirements and budgetary constraints, especially now, will begin to shape practice. Culture colors the value that a provider places on dependency or autonomy, the meaning that she gives to making eye contact or averting gaze. A provider's cultural constructs in concert with role expectations and personal perceptions impacts the interpersonal atmosphere of the whole program. The consultant has to understand and acknowledge all of these influences, whether consulting about an individual child or the whole program. And that as we come to understand these multiple influences, we can then contribute our understanding of these factors when assisting consultees in sorting through and coming to solutions to current conundrums or concerns. The next aspect of the consultative stance is to avoid the position of sole expert. Convinced that positive change occurs only as all participants provide and combine their unique perspectives, the consultant's job is to seek to legitimize and heighten the provider's and the parent's sense of their expertise. How do we elicit a provider or parent's knowledge, understanding, sense of expertise? I think doing so depends on the consultant's abandoning the notion that she is the sole expert. And I don't mean, again, to suggest that the consultant doesn't have to have and possesses crucial knowledge. But what I'm suggesting is we have to avoid the pull to offer that knowledge, that advice immediately so that we don't preclude others from offering information essential to constructing, co-constructing a complete picture of a child. For instance, as an example, a director who's distraught by the frequent biting of a child in the toddler room starts to tell the consultant that she questions the competency of those teachers, who she thinks should be able to curtail the behavior. And a consultant who wishes to be immediately responsive, particularly to a director who, let's say, maybe hasn't invited the consultant in very much, and maybe even the consultant is convinced that her good idea could immediately remedy the problem. So she suggests to the providers a strategy. What that does is it inadvertently aligns with the director's suspicion that the staff's inadequacy accounts for the problem. If it were that simple a solution, they should have come up with it. The consultant's offering is conversely seen by the teachers as an indictment of their competence and not taking them and what they've been trying so hard to do into account. So what the consultant finds is that reluctantly her idea, not a bad one, that there be a teething ring on a string, it's constructed, but most days the noshing necklace remains buried in the child's cubby. And guess what? The biting goes on unabated. I'm suggesting that the well-intentioned offer was doomed to fail, not because it lacked validity, but because the process of creating the idea bypassed the very participant on whose success or failure it rested. A consultant's advice, no matter how ingenious or accurate, is useless if it does not consider the consultee's feelings about and understanding of the situation, and ultimately their willingness to participate in making change occur. Consultation is only effective when the consultee participates in the process and takes the lead as the agent of change. How do we support taking that lead, being the instrument of change? I'm suggesting that integral to the process is wondering with, not acting upon, the caregivers with whom we are consulting. Wondering with another elicits their involvement in the process and properly preserves the sense of their being the agent of change. Pondering together also demonstrates to the consultee that understanding a child's behavior, understanding a classroom routine, that understanding is a process, not a moment. Asking elicits the providers or parents' currently held ideas, maybe misperceptions about why a child is behaving as they are. Often the way that behaviors are labeled immediately assumes we know the cause. To give another example, a child who cries constantly and can't nap without constant comfort is labeled by her providers as spoiled, locating the cause of the behavior primarily with the parents. This assumption, suggesting quickly that the child is spoiled, stops the search for other causes, and it may preclude providers from imagining that their effort will have an impact. If the problem resides in the parent's behavior, how could anything that they would do make a difference? What I'm suggesting about the wondering stance is that the consultant's curiosity can help to identify obstacles to change in the provider's perception. And it also suggests that multiple or alternate views can be entertained. Wishing to understand how meaning is ascribed and broaden the possibilities a consultant could ask something like, what is it in the ways that you see the parents relating to her that convinces you her distress comes from overindulgence? Questions can identify, but also serve to shift providers' views about a child or family. I actually see inquiry as an intervention that's aimed at enhancing reflective capacity, one of the primary aims of mental health consultation. If we think about it, what happens when you're asked a question, which in fact I just did? Knowing I can't get a response from you in a webinar, but whether for a nanosecond or over time for an eternity, what questions does, what compassionate inquiry does, is create a pause, a space for reflection. Successful consultation relies on the consultee's capacity to reflect, as well as to generate expanded notions of causality, particularly as they pertain to the possible reasons for a child's behavior. The consultant's request of the provider to consider both her own, so these questions, this inquiry as intervention pertains to also asking questions of the provider about their own subjective experience. But these questions about one's own and another's experience also suggest that internal experience exists, that we go beyond behavior, and that not only does internal experience exist and is important to get to know, but that internal experiences can be responded to. The provider who feels ineffective with a distressed infant is encouraged to consider her own reaction as well as the reasons for the child's distress. First, the consultant would empathize with the consultee who feels insulted in the face of perceived rejection by the infant. The consultant may wonder, what is it about this little one's crying that feels like a kind of personal slight? This line of questioning demonstrates awareness at several levels. The tone and the content of the consultant's question hopefully conveys an appreciation for the consultee's subjective experience. A consultant's inquisitiveness infers that individuals perceive the world through different prisms of experience, and that she wants to know something about the idiosyncratic way in which the provider is looking at perceiving the child. Of course, and I want to stop here to say, our inquiry cannot be inquisition. If we are indicting people through our questions, if we are interrogating them, if we've already come to judgment about them, they will, of course, feel it. Our questions have to genuinely come from a place of authentic curiosity and interest, a place of wondering but not thinking we know. To intervene optimally on behalf of another, any of us must recognize that our worldview is to some degree our own construction, and that by wondering with providers, we are also gently pointing this out. Through this seemingly simple exchange that I just illustrated, the consultant, one, responds to the provider's emotions. It introduces the idea of internal representation. It brings attention to the intersubjective field between the consultant and the consultee, but also between the provider and the infant who she feels rejected by. And it elicits reflection and possibly begins on the road of garnering new ideas an interest in new ideas about the meaning of a distressed infant's gaze aversion or pushing the provider away. New ideas about the meaning of the child's behavior. By cultivating an environment without appraisal or judgment, mental health consultation affords opportunities for inquiry into oneself and one's practice, the internal change we're trying to evidence for and with providers. Learning through a reflective process facilitated by the consultant is, I believe, paramount to passing along information and vital to the provider's enhanced ability to be responsive to children. So as we move along, you've undoubtedly noticed that I've spoken almost exclusively about the consultative stance, the consultant stance in relation to adults, but also to individual consultees. We have to give equal emphasis to attending to the myriad relationships in a child care community. While each caregiver's perspective must be heard and valued by the consultant, so it must be heard and valued by those with whom she works and by the parents who she works with as well. The consultant communicates through empathic inquiry and calm comportment that varied points of view are not only acceptable in a community like childcare, but in fact are enriching. When two providers hold diametrically opposing views about the meaning of a child or a parent's behavior, the consultant wants to convey intrigue, not, okay, let's get to the bottom of this about who's right attitude. She might posit something like, wow, this is fascinating. What did the two of you think accounts for you seeing the same child in such a different light? Because I think both of your experiences are valid and we could learn something from each other. The consultant in this seemingly simple statement and question is demonstrating, one, that various views can be held and heard equally and actually add to the understanding of a child or a situation. We don't count on our regulated way of being to handle high affect among providers or between providers and parents. So, because we're not always there. What I'm suggesting is that while this countenance in the consultant helps in the moment to mediate conflict or disagreement, we're not regularly present to mellow or mediate. While we're working towards a child care system's ability to tolerate differences and some discord, I'm also encouraging us to assist in co-creating agreements, of course, with the involvement of the director of a center and her staff about how to handle conflict, starting with understanding how it's already either tolerated or eschewed, and to begin to help programs allow room for different perspectives. Next, we will think about hearing and representing all voices, always with permission and usually usefully distilled. Whenever necessary, the mental health consultant represents the perspective of one child care community member to another, with the eventual aim of increasing the adults in the child care community's capacity to and belief in the usefulness of communicating directly to one another. But at times, this may mean that a consultant chooses or is asked to meet with an individual provider to be able to learn about her unique perspective, but also to help her to be able to couch her perspective in ways that can be heard by others in a beneficial way. And importantly, I want to add that the consultant gives voice to, particularly amplifies the voice of those with no words, the children, so that whenever we're constructing hypotheses together, whenever we're representing a particular situation, the consultant, in addition to hearing the voices of the adults, adds and represents the voice of the child, or tries to elicit it from those providers and parents who know the child better than she. Patience is also a part of the consultative stance. Just as we encourage and attempt to foster patience in caregivers' relationships with children, we as mental health consultants must also be patient with the child care providers and the pace of systemic change. We all know change as individuals takes time. Change in systems takes even more time. What this means, in my experience of training mental health consultants and supervising them, is that it is necessary that we help mental health consultants focus on the future children in the care of the provider or in a system, not exclusively on the children currently in the program. If we're really seeking internal change in providers, classrooms, and systems, that change may not be able to be evidenced immediately or in response to the needs of a particular child. But we have confidence and belief that internal change will have a far greater and long-lasting impact, affecting more than the immediate child or family. Patience for having an effect in the long run, I think might be especially difficult right now when current needs are pressing and the future of child care and for child care providers feels a little bit elusive. During the current crisis, we need to promote patience in small doses, trying to exercise endurance in the face of uncertainty for ourselves as well as those with whom we consult. And the last element of the consultative stance is holding hope. I have found that child care providers often lose hope in the face of daily crises and persistent challenges, and this was true way before our current situation. It's the consultant who I believe must and can maintain her belief in change in a slowly shifting system. The consultant can also hold hope for the child care providers and parents because typically she is one of the few people in the constellation of providers that regularly has the luxury of stepping out of the seemingly static system to have a perspective that allows her to refuel, but also a view that allows her to see future possibilities. Here again, sustaining this stance of holding hope, may be really challenging, and the forms that it takes may need to be adapted to the current moment. But I would also suggest that there's no time that I can think of when the concept of holding hope has been more important for all of us, and particularly for our work in mental health consultation. So I end with a quote about holding hope from someone who I respect and who I turn to a lot. is Rebecca Solnit, who wrote a book called Hope in the Dark. And one of her quotes around hope is that, quote, "To hope is to give yourself to the future. And that commitment to the future is what makes the present inhabitable." So in hopes that we can create for ourselves and with and for others an inhabitable space to hold hope, I will end. And now we will have a few minutes for questions, which I will ask Evelyn to relay to me, and thank you very much.
And also, please remember to fill out the evaluation. It's really important. We take very seriously your feedback. So here's the first question. I have been advocating in this work for a long time and have experienced change with co-creation of alliance and learning and growth with direct service staff, but unfortunately not with the leadership. I have not found the way of being that influences change at the leadership level. Do you have any suggestions on how to adapt my stance?
Well, I want to begin with the idea that I think that leadership in programs and systems is often the most arduous change that we need to help make, but also the most crucial. So I really appreciate this particular participant asking about leadership. And I don't know, I think in the last presentation, I talked about what I see as an integral premise of consultation related to the ways in which, from the very beginning, we make sure that we have agreements with the leadership, with the directors of programs, about a partnership, and that cultivating that partnership, and I don't mean to suggest that if we haven't done this in the beginning, it is too late. Quite the opposite. That I think we want to revisit, and I would suggest again that this time of crisis might be an optimal time to revisit our agreements of partnership with leadership. Leadership may not feel it right now, but I would suggest that the leadership of centers having to make incredibly difficult decisions about reopening and revamping, as I referred to it, are in a position to need the greatest support. And yet often, I think, and inaccurately, we are told as leaders that we should go it alone, that we should know all there is to know. So that I think this is a moment to try to reestablish with the leaders in a program, site supervisors or directors or administrators, how the consultant can contribute to the thinking that needs to go on right now. I don't know that it's necessarily a different style of or comportment, but rather a different agreement about what the relationship could contribute. I think that it's a misperception that is common in mental health consultation, that this is a service, because this is a service for children and for individual children, that it is a service on behalf of only those who are directly involved with the child. And that therefore that can mean that leadership sees themselves outside of this. And that what I am suggesting is that we reestablish through some of those questions about what is expected by leadership, of how consultants will function, and what's important about the partnership that we describe, what's important about, and how we need the partnership of the director in order for our efforts to be efficacious. I hope that's a little bit addressing of a hard question.
Absolutely. And I just want to let people know that the link to the evaluation is in the chat box, just a reminder. Next question is, it makes sense that providers who can rate themselves highly on cultural competency will be more effective. I'm curious as to what you would recommend for providers to become highly competent in cultural competency. How do providers get there?
Well, one, I want to say that for any of us, or at least in my experience, that developing cultural awareness and humility, as well as cultivating a stance about the importance of equity, is an explicit commitment and a lifelong one. And that what I would suggest is that we turn to some help of people who have been in that process for longer than many of us, speaking for myself. And this is where I refer us to much of the work that's been done diligently for decades by the two groups that I referred you to in the slide, the Diversity Informed Tenants Work Group and the Indico Cultural Center, that provide not just training, but really a framework for beginning the process, an individual and collective process in the work of infant mental health, for infant mental health professionals, to begin to cultivate first our self-awareness and then to begin to, on that journey of continued cultural competence. I also think and want to add that study that Annie Davis did, and the providers that were looked at were providers who were, meaning providers in this case, mental health consultant providers who were in an organization where that organization saw the focus on equity and cultural sensitivity as central to workforce development and ongoing support and training of their mental health consultants. So that what I'm also suggesting is that while becoming more culturally sensitive and having a focus on equity is an individual effort, it is greatly furthered when supported and acknowledged as integral to the work by the organization in which a mental health consultant lives. So also encouraging within our institutions and within our professional development opportunities for mental health consultants that the raising of equity and cultural sensitivity to the top of our areas of expertise and competence is essential.
Another question around diversity. Some professionals who consider themselves the most culturally diverse don't often recognize their own implicit biases. How would you approach this if you saw this?
I think by virtue of the term implicit bias, it suggests it is unconscious. So that this is where, for me, that our understanding as mental health professionals about the unconscious and how the unconscious is at play for all of us. Not that any of us have to be Freudian, but Freud said that about 90% of all of our behavior is motivated by unconscious processes. So first, by being gentle with ourselves and others, that most of our behavior is based on unconscious motivation. Also suggesting that it is very difficult to identify one's own unconscious. So that this is where we have to have enough trust in a developed relationship with another, where they will allow us some access to the very delicate territory of one's internal processes, to be able to posit possibilities about something interfering with the ability to see a child in what seems to us an accurate way. That what I'm suggesting is that there has to be enough trust where someone allows us to think with them and bring to light areas that are currently we are blinded from, and that we can begin to bring to light gently enough with each other that we can afford to see them. That's what defenses are, right? Is that we are too worried about seeing that we defend against it. So that what I'm suggesting is in mental health consultation, we begin to, without judgment, start to ask that others are able to see those areas that reside in the dark recesses of unconscious and can be tolerated as possible.
So there's actually two questions that are very related. What language would you use to explain your role to a consultee when the consultee has different expectations of the consultant? So one example is a daycare provider that wants the consultant to focus on the behavior of a child. And another question, which is very similar, is particularly in Head Starts, they want to go in and immediately develop a behavioral plan to change behaviors without giving us the time to respond in all the ways you have presented. So I guess the real questions are, how do you really kind of talk about your role and define your role when people are looking for you to do very child-specific interventions and to really resolve behavioral problems?
Yeah. So those expectations of centers, first of all, I want to say that if we know those are the expectations, we've done part of our job already, right? That we've asked the questions or observed or inferred and elicited what the expectations are of the providers. I think one is we do want to describe how we see our role. And I think that we can find words that describe the importance of the relational context that I just described. What I mean by that is that we can say things like, that in order to be able to attend to the behaviors that concern the providers or program, it will be necessary for us to understand a program philosophy, to understand the provider's perspective about the behavior, so that we're immediately, as I hope I was suggesting, that we're immediately suggesting that they, not just the behavior, but that they are integral to the process of consultation. What we do in the beginning, I think, is to be able to describe our role. But we don't ever depend on a description to be taken in and of itself. That what we have to do is to demonstrate over and over the utility of the stance that I've just presented. So that one of the things that I like to do is not to present my role as in opposition to what is being presented to me, not as a point counterpoint, but to talk about how we can best reach the goals that the center or the provider is looking for. We do want to be able to help them come up with a behavior plan, or we do want to genuinely help them better understand what's making this child distressed and distressed, therefore distressing. We want to talk about similar goals, that in saying things like, yes, I very much feel like I can be of help in thinking about how we could address this child's distress or this child's behavior. Let's think about how we're going to get there together. So even the word together, and I'm not suggesting that saying it once is going to be enough, but how we're going to get there together immediately suggests that this is a collaborative effort, not something that you as the consultant is going to do by yourself, or that they will have to continue to take the burden all by theirs. But then we begin to describe what part mental health consultation and mental health consultants contribute to the effort. And that what we would address is this idea of collective expertise, to begin to describe how we are dependent on the knowledge of the provider, what their current ideas are about the behavior, and the parents to have some understanding of what is contributing to this child's distress, which already, by describing the process of gathering information, what that already says that it is not a matter of a behavioral plan solely, but rather about understanding what the meaning of the child's behavior is that is crucial to our being able to address it.
and that we also talk about the ways in which we could give. I often talk about how I could give recommendations early on, but that what I am sure of is those recommendations, those behavior plans, would be ill-informed and therefore likely to fail if they are not co-created and based on the information that I can gain only from collaboration with the center, director, the teachers, and the child's parents. I also want to acknowledge the wish, because underlying asking us to fix a child or give a behavior plan, what's underlying that? Underlying that, I believe, is a wish that there would be a simple and immediate fix. What's underlying that is often the belief that providers are not adequately positioned to help a child, so that what I'm wanting to do is to give voice to some of those feelings, that I can imagine the wish to have a behavior plan that would remedy all of these difficulties quickly, and yet it would be a disservice to suggest that it could. And I realize that's both a long and an inadequate answer to a complex question that we encounter all of the time in mental health consultation. But I recognize that we are very, very near the end of our time together. So I really want to thank you all for your participation and for the evocative questions. This is emblematic of how questions elicit reflection and further our growth. And to say thank you very much and turn it back to Evelyn.
Kadija, thank you so much. This has been such a rich presentation. I think the questions are really so right on target, so we really appreciate it. We hope you're all going to join us next week on June 4th for the third of the series. And also, please do complete the evaluation before you sign off. It's been a pleasure having all of you. Thank you for joining us, and we hope you'll join us again next week. Thank you.
Thank you.